The pandemic overnight changed the way heart failure care could be delivered. So we were very used to seeing patients face to face. They were very used to being able to have instant access to us so we could examine them, see what was happening. That changed, and we had to do it all remotely. And it was amazing to see how quickly we could change. It was a very nerve-inducing time for both the clinical teams and patients, but we did change overnight. I think we'll go back to a hybrid approach where we have remote monitoring, remote consultation when it's appropriate, but face-to-face also, to develop rapport and to sort out some trickier problems. There's a whole range of remote technologies that can be used, so technically it's possible. Some of them are very simple, standalone systems like weighing scales, Bluetooth, and blood pressure cuffs and symptom collection. Others are taking data almost in continuous streams from implantables like CRT or ICD. The challenge has been trying to integrate all of that information and make sure you don't overreact to it. So it's more data and more sense, so better decisions, not just more decisions. But I think the most recent version of the Heart Failure Association guideline is moderately supportive and says that it can be done and that it's probably as good as normal care, sometimes a little better, and most systems will have to integrate it in some way to their usual offering for heart failure patients. Before the pandemic, remote monitoring was seen as a bit of a minority interest. It was interesting if you wanted to do it, but there wasn't much incentive to do it. With COVID, reimbursement really lined behind it, regulators were much more permissive, and patients, their families, and clinicians realized the sense of it. So it's really changed. So people use the word tech acceleration, where in a few months you had 10 years of change. And I think that's very true for heart failure care. One of the big challenges is how to decide what is good, because there's so many potential technologies that could be used. The question is, where does it add value? And actually, is it going to fit into the workflow? So who's going to look at the information? Who's going to act? And will the nurses, doctors, and patients actually change what they're doing in response to the remotely collected data? Otherwise, there's no point. And I think we're moving not just from detection of deterioration, but helping people maintain their own health and lifestyle with these tools, which vary from just apps on a smartphone all the way through to quite complex implantable technology. It's an exciting time, but we still haven't fully navigated our way through this. There's a lot of studies going on all the time in these technologies, and I think tech developers now understand that cardiologists need good, firm evidence to go into their guidelines, to change practice. Some very large studies looking at, for example, ECG detection remotely, some studies in heart failure using implantables with hundreds and thousands of patients going into that randomized trials, because the regulators also want to see hard evidence that this works. The only thing that's changed in the conversation is maybe it doesn't have to be hugely better than standard of care. As long as it's the same outcome, then it's possible to use this, particularly for convenience for patients and families if they're frail and elderly and live far away from a heart failure centre. Exciting time for remote monitoring in heart failure. I think it's going to be a hybrid approach. As we come out of the pandemic, we're going to have a range of offering, some of it face-to-face, some of it remote consultation, some of it remote monitoring. Right tool, right patient, right time, I think has to be the mantra, but most services will ultimately end up offering a range of services and choose what's most appropriate at that time.